So good morning, ladies and gentlemen. This is 10 o'clock and it is Monday, the 27th of November. I will ask you just quietly to join your thoughts together so that we can start this meeting. I understand we have some technical problems this morning. There will be some paper copies of the agenda and the papers, which no doubt you have read in detail. So it'll just be an aid memoir and a refresh for everyone. So I do accept it's been a bit of a marathon session the last 3 weeks. November has been 3 health meetings on the bounce, but this is not only the last scheduled meeting in November, drum roll, for committee, it will also be the last scheduled meeting of the calendar year, you'll be pleased to know. So thank you to all committee members for their hard work, passion and dedication this year. It has helped us through a really heavy programme, especially of late, and that ignores the working groups that are beavering away merrily behind the scenes on things like women's health, integrated care hubs, and providing social care assurance. So given today's meeting is the last scheduled meeting before Christmas, there are some mince pies and chocolates outside. Please feel free to help yourself alongside the teas and coffees. It's probably a bit too early, given that we're only in November, probably too early in festivities to have any mulled wine, so you'll have to experience that separately and enjoy that, and my apologies that there isn't any at this hour in the morning. So this is Staffordshire's Health and Care Overview and Scrutiny Committee, and I am your Chair, County Councillor Jeremy Pert. Welcome to our guests in person and equally online. And equally welcome to councillors. Thank you for all your commitment over the last few weeks and the last year. Let's get down to business. May I remind committee that today's meeting is being recorded, and for those who want to watch it back, the recording can be found on the County Council's website. The meeting is also being beamed live for all those people who want to be involved, and it will cut off, the equipment will cut off 20 seconds after the meeting has finished. All voting committee members are in person, and there is a variety of in-person and virtual attendees as our guests. So could I ask our guests to accept that members have read the papers and digested the papers provided, and as a result restrict their comments to maybe somewhere between 5 and 10 minutes, something like that, and so we can focus more of our time and attention on asking questions. And secondly, can I just say that that we should focus on the tangible outcomes for the residents of Staffordshire using the data and our experiences to sharpen the quality of debate and scrutiny. So on to the agenda proper this morning. First of all, apologies. Zach.
Good morning, Chairman. I've received apologies from Councillor Hewitt, Councillor John Jones and Councillor David Williams, with Councillor Stanton attending as substitute.
Thank you, Councillor Stanton. You're most welcome. Declarations of interest. Anne Edgler.
Thank you very much and good morning everyone. Yes, I'm Partner Governor from the County Council on the Midland Partnership and Foundation Trust. Thank you.
Thank you. Bernard Peters.
Good morning, Chair. Thank you. I'm the Local Authority appointed Governor at UHDB.
Thank you. Keith, do you have a declaration? Okay, that's fine. You're trying to confuse me already. I know it's not difficult, but it's a good way to start. So, item 3, the minutes. So, can we approve the minutes of the meeting held on the 13th of November 2023, which relate to the West Midlands Ambulance Service? Are we happy that they are a true and accurate record for those of us who are there? Yeah, I'm getting nods from around the table. Yep, that's fine. Yep, okay, they are approved. I will sign those on your behalf. Item number 4, we didn't really mean to just send you a set of minutes you've already approved without a covering note, but effectively the minutes that were approved for the meeting on the 31st of July 2023 recorded accurately those members of the committee who were present, but we didn't record accurately that Councillor Bob Spencer, who is the Chair of Safeguarding, and his Vice Chair, Councillor Burnett, were also in attendance. So could we retrospectively amend those minutes to show the attendees accurately reflecting who did turn? Yep, absolutely. Okay, so that's carried, and let's move on to item number 5. And we're 5 minutes ahead of schedule, so that's even better. So maternity and natal services update. So Helen, are we handing over to you first, or are we handing over to Gina? Which way do you want to do it?
So it's myself this morning, Chair. So I'm Helen Slater. I'm Associate Director of Transformation at Staffordshire and Stoke-on-Trent ICB. I have my colleague Karen here. Do you want to introduce yourself, Karen?
Good morning. Karen McGowan, Associate Director for Nursing Quality and Maternity.
So the paper that you have in your pack this morning is an overarching paper regarding maternity services in terms of the work programme that's being undertaken at the moment, but also information around the challenges that the teams are facing across the provider units, and also information regarding the service change process for the temporary changes to the birthing service at the 2 freestanding midwife-led units. Because of the workforce challenges at the moment, there's representation from myself and Karen at the ICB. If there are any clinical questions or any organisational questions that you would like us to take back to the team, we'd be happy to do that, but we'll answer as many questions as we can this morning for you. Thank you, Chair.
Thank you. Appreciate that. And I'm looking quietly around the chamber, and I think is somewhat indicating. Are you about to...
At the finish of the presentation? Yeah, okay. Yes, I've got a few questions, actually. Thank you very much.
We're with you. Thank you.
Thank you. And good morning, and thank you for attending the meeting. Yeah, I mean, on page 81 of the Ockenden report, it says every trust must have ensure they have a partner safety specialist dedicated to maternity services. Is that in place? Is that person in place?
My understanding is that Ali Budd, who I think presented to you last year, who's the lead midwife for the ICB, will be and is that patient safety specialist. I think when she came across to us a few years ago, she'd already started that work. But I will double check, but my understanding is she is that person.
Right, thank you very much. Can I carry on? Thank you, Chair.
Yeah, and just as a point of clarity, I think Karen's exactly right. About this time last year, post-Ockenden, we did have an assurance session specifically to look at that. But you may just want to take your question maybe a step further and link into the situation at Chester, and whether we have an assurance in terms of the speaking out policy. I know we've seen this at committee, but sometimes it's useful to have asked the same question to different people.
Yes, it's interesting because the Chester situation, obviously, whilst it happened in maternity services, is relevant to services beyond maternity. And I'm sure Tracy, who's online, would be willing and would love to answer this question. So yeah, maternity services, absolutely looking at the processes, learning from what they know already. So just to add really that is happening, we're getting assurance it's happening, but the learning from Chester is above and beyond maternity services. So it's across organisations. They're all looking at their freedom to speak up policies, looking at their processes, reminding staff about behaviours and their responsibilities. And so if Tracy was here, I think actually she would probably answer that question from a far broader perspective actually than just maternity services. So yes, and broader.
Thank you. Sorry to interrupt your question. I'll come back to you in a minute, if I may. In answer to your points, in fairness, Tracy has presented on this. I just wanted to make sure that we took several soundings within the organisations. No disrespect to the answers we've had previously. Sometimes it's useful. And I think your point about it is a wider learning, I think, is exactly right. And thank you for your response. Anne Edgeler, we're back with you.
Thank you very much, Chairman, and thank you for your response. I know this is probably a very tricky question to answer, but knowing the growing population within the Staffordshire area, especially in Stafford and in Lichfield, how do you see the Samuel Johnson and County Hospital moving forward with maternity services, please? I've still got some more questions, thank you.
So that's why we've entered into the service change process. So we recognise that it's been a number of years since the units temporarily closed, initially due to the COVID response, but Over the last 12 months, certainly, the challenge has been around the workforce. We've seen both of the organisations have more positive recruitment campaigns and been able to recruit more midwives. Some of those midwives are more junior midwives, some are overseas, and there is a programme of work to get those midwives up to be able to support both the community services and the hospital-based services. The challenge at the moment is we're still not up to those full workforce numbers. So we are undertaking a process where we are looking at all different proposals. So when we came out of COVID in 2021, we looked at, rather than a 24/7 staffed model at the freestanding midwife-led units, to look at an on-demand model where the midwives would meet the ladies at the birthing unit, and that was the model that we were hoping to move forward with, but we've been unable to progress with that model. So the process that we're undertaking at the moment is to go back and look at all the different models, taking information from the national best practice, looking at the complexity of the women that are presenting now to the units, looking at the eligibility of the type of women that would be suitable for birthing in those units. So they were for low risk women. And being able to look at what the clinical model needs to be, but also what the workforce model needs to be. So that process is is up and running at the moment, and we are looking to hold patient and public and stakeholder meetings so that we can talk through those and look at the impacts in terms of the women and families that would be potentially using those services and the impact of any changes that we would put forward. So we're in that process at the moment, but we're not able to tell you there's been no decision made, so we're not able to tell you the long-term model at this stage.
Can I come back, Chair?
On that one, or ask another question, because there's a few other people behind you. So if it's another question, I'll bring you in a bit later. If it's just in response, then please feel free.
No, just to comment really, I'm really pleased to hear that you're going to have public meetings regarding that. I'm really pleased to hear that. Thank you. I have some more questions, but
I'll add you to the list. Thank you. Janice.
Thank you very much, Chair. Good morning. I should just point out by starting with Samuel Johnson's actually in my county division in Lichfield City North. And so, as you can imagine, there's a number of questions, and I have specifically on from that, following on from Councillor Edgeler. I was intrigued with the comment about holding a public-facing deliberative event as to what that actually meant. Is it a case of we're sharing the information, and there's some useful information in the pack about the amount now that were being delivered previously at Samuel Johnson, if I can just focus on that one in particular, Chair, compared to about a third in comparison. It may well be the complexities, it may well be the birth numbers. So if you could just, it was the deliberative event. I wondered if that was some type of conclusion, as opposed to, are we sending out information or are we gathering information from those? Because there would be, as you can imagine, an appetite for that in Lichfield City North in particular. And also, with regards to the numbers that are going through, is it those complexities, which means that some mothers aren't necessarily appropriate to birth at those units, or is it the amount that's going through in those particular areas? If I could just start with those two for the moment, please, Chair.
Thank you.
Okay, thank you. So the numbers that were going through the units prior to them temporarily closing was lower at County Hospital than at Samuel Johnson. Probably because of the geographical area, and we recognised that there were women from outside of Staffordshire that were utilising Samuel Johnson, so we are working with Derby and Derbyshire ICB as well. The numbers were still low for those people coming from outside, but we recognise that there is still an impact in terms of the services that we're able to offer women. The review that both of the providers have undertaken demonstrates that the complexity of women presenting, but in terms of being able to monitor women and see that has risen quite a lot since before COVID, and so that's where the workforce numbers need to reflect the type of women who are medium and high risk and have the services in place for them, and then looking at what the impact would be for those people that are low risk. We recognise at the moment that we've got temporary pause on the home birthing service as well, and both of the organisations are looking to reinstate the home birthing service so that we can offer that choice as well for low risk women. So the deliberative event will talk through the proposals that we've looked at across the organisations and within the ICB. We will ask for alternative proposals to come forward if people have got those. We will look for the impacts in terms of each of those different proposals so that we can then take that away and look to build that into a business case as we have done with other service change processes, but very open, and we will share the information that we have to date, but happy to take feedback from patients, public and stakeholder at those sessions. And we have, to support this process, we've got engagement through the Maternity and Neonatal Voices Partnership process and the support there. But we have also set up a patient panel that people can register for, and we've circulated information through the maternity units, through community sites, so that people can come forward and share their views with us as we go through this process.
Janice?
Yeah, thank you. I do think that's a really important activity with regards to the appetite locally. We can appreciate from people, wanting to see the unit being opened again, but realistically looking at the eligibility, if you like, of people to be able to go there. And obviously that's in the mother's interest, not just in what can be provided in terms of a practical resource available. Although I do also note in the report that it says that the birthing units aren't an attractive place to work for midwives wishing to develop their competency and experience. And on that basis, I just wondered how on earth we would possibly get to the point where we could do, notwithstanding your previous comment about the fact that there's quite a young, if I can use that word, level of workforce coming through in terms of midwives and their experience. I'm using that term if I'm understanding that correctly. So how do you think that will be managed?
So in terms of the obviously we're looking at how the service was run prior to COVID. So that was a 24/7 staffed, both units were 24/7 staffed. And because of the low numbers, some of those midwives may not deliver a baby for a couple of days. So obviously we need to make sure that they're maintaining their skills and competencies and that it's an active place for them want to work. That's why we've also looked at some of the other models in terms of linking in with that community midwifery service, where the midwives may follow the women and meet them at the unit. That was the on-demand model that we looked at previously. And so it's looking at all of these different ways that we could potentially deliver a service to low-risk women, but recognising the challenges that we have around the workforce at this point in time.
Janice?
And it's just one quick follow-up on the same sort of basis, because I mean we're putting a lot of emphasis on the data and the numbers and things like that coming through. I noticed one of the first parts of this particular report was looking at some of the governance arrangements with the neighbouring integrated care systems, and I appreciate that in my locality, it may well be the same for some of my colleagues here, that those mothers go to Wolverhampton Trust, so whether they go to the Manor or go to New Cross, and how we are bringing in that data. And you've also already mentioned about those that want to birth at home, to make sure that we're getting the most accurate picture that we possibly can. How are those being covered off? That was the last one for me for now. Thanks, Chair.
So one of the key areas of work that I've been brought in to do really is to look at that governance process. So how are we hearing what we need to know? How are we getting what we need? And you're absolutely right. We've got UHM in the north. We've got a lot of delivery in the south that's disparate and across boundaries. So how it works is currently, or previous, in the summer, I suppose, up to the summer, we had people from rural Wolverhampton and people from UHDB coming into our monthly meetings, midwives coming to talk to us, making us aware of what we need to know, keeping us informed, and was really helpful. The challenge with that is they will already have reported into their own LMS partnership boards in the Black Country in Derbyshire. So there's something about taking midwives, busy midwives when we're short-staffed, essentially, coming into meetings to report again on things, and also we're getting a distilled version of what they'll already have said to their own boards. So the governance process we're looking at is we're putting ourselves into their area. So we've got 2 really excellent midwives in the ICB, quite apart from the lead one. And they'll be going to the meetings in Derbyshire, the meetings in the Black Country, to hear those full discussions, those full conversations. I'll probably be attending the partnership boards so that we can try and absorb and pull in and understand what they're sharing with their areas as well, so we're as well informed. So we're trying to do it in such a way that we get all the information we need, but we're not impacting on the midwifery workforce, who are better served getting on and delivering babies, essentially. So that's a big piece of work that I've been involved in predominantly.
Thank you, Janice. Thank you. Charlotte Atkins.
Thank you, Chair. It's very worrying to see that Stoke-on-Trent has the highest neonatal mortality rate in England, and that Staffordshire and Stoke-on-Trent ICB has the second highest in the UK. I would have hoped that that would have required urgent intervention to deal with that issue. Now, I'm sure there are lots of reasons for that, but one of the areas that stands out is one of the points of concern that you've identified is the influx of new recruits and induction of labour as well. Is workforce, workforce seems to be a big issue because you've had 4 consultants on long-term sick. What is going on that not more attention is being given to the fact that we top a chart we don't want to top in terms of mortality? We've heard so many awful stories about maternity failures. But it seems to me that we top the whole lot. So what urgent intervention is taking place to resolve this issue?
Thank you.
Yeah, and I think we feel exactly the same. The urgency you're talking about, it's now our key area of focus. If I pick up those bits individually, if I do the neonatal consultants first, then I'll talk about our process, and then induction of labours, which is slightly different. So you're absolutely right. There's been a real challenge around the neonatal consultant workforce to the point where currently there's an arrangement where babies who are born under 27 weeks in Shropshire and Telford come across into Staffordshire to be cared for because we have a level 3 unit. And there was a challenge at one point whether we had the workforce to be able to continue to offer that service. And that was looked at, constant monitoring. What has happened was, at the time, 8 neonatal consultants, 4 of them were on long-term sick, which in itself is something that the Trust is looking at to try and understand why. Pleased to report that they have now recruited, and I think they've just got 1 vacancy now, so that workforce has increased. So that's a lot better than it was. I think the thing about the data as well is the data that's reported here is the Embrace data, the national data, and it's reported annually, and there's a 2-year delay on that data. So there is something about the ability to benchmark yourself, so the ability for UHN to benchmark themselves against others when it comes to this data. So for assurance, we're asking UHN, are you monitoring your data? Do you know what you're doing with your data? They do, but this benchmarking data only comes out annually and it's 2 years delay. So that, when it does come out, it does grab the attention, it makes us look at it closer. So there is work to do there. I think there's things to unpick around, so why have we got that high number? Because it's awful, it's dreadful. Is there something about, and I don't know this, there's something about the chances they take on younger babies that other areas don't take? That may or may not be the case. However, the data needs to be dissected. It's a piece of work we're looking at really closely because we need to understand it. There was a neonatal improvement group that met monthly. And I think that stopped at the beginning of the year because of the workforce challenges and the ability to release staff to go to those meetings. That has just been resurrected. So there's monthly neonatal improvement group meetings, which will look at these figures, look at the actions being taken to better understand them. The other bit that's happened in tandem, and I think it's almost coincidentally, is John Rouse from Stoke leads on the Children and Young People Programme Board for the ICS. And what he put in place in the summer was a review of infant mortality. And they were looking at why our babies are dying. And certainly the majority of them are in those first 28 days in our neonatal, which is what this data's saying. And so what he's talking about is what can we do? So there's things around that are already in place around breastfeeding, there's things around tobacco dependency, and they're quite big areas, big projects that are being worked on. What John's talking about is let's look at the mothers, yes, when they're pregnant, but pre-pregnancy as well. Let's look at housing. Let's look at, we've talked about lead piping, conditions of housing, how we make our mothers to be as fit and able as they can be. So again, that piece of work is happening. And what is really good is it's joined up work. So it goes across our neonatal consultants, it goes for the local authority. So we've got all partners involved in looking at that infant mortality, which will focus on neonatal mortality as well, because we know it's an area we need to look at. Induction to labour is slightly separate. I'm happy to answer it, but you've got a question.
I hope we're not falling back on the old adage of blaming mothers, because it worries me that you're sort of saying basically that, you know, issues around breastfeeding, et cetera, because that really worries me, because it seems to me that, you know, this is a scandal, that we're not just a little bit above the rest, about the average, we're well above the average. I mean, disastrously so. And what amazes me is that we don't seem to have established what the reasons are. Now, one of the issues, as I identified earlier, was the influx of new recruits. So we may not have vacancies, but do we have the skill levels? Do we have the skill mix that we need to have for what is clearly an area where there are a number of very significant challenges in terms of neonatal mortality? And another issue is I'm hoping we're not, you do mention within the document something about international midwives. I do hope that we're not denying other countries their own midwives because we can't recruit and train our own.
Back with you, Karen.
Yeah, picking up on the first points. No, not at, I mean, I'm a mother of 4 children. I live in your area, Janice, and a lot of us we are passionate about mothers and birth, and absolutely not blaming mothers at all. What evidence is showing us is that tobacco dependency is a key factor. So that's really one we've got to go at. And when I talk about the housing, I actually think that's ourselves looking back and saying, actually, what do we need to do about it? What's the state of our housing? What are we doing to our mothers? So it's absolutely not blaming mothers. It's looking at what are the social factors that we need to take responsibility for to make sure that these mothers are in the fittest place they can be when they choose to give birth. Regards the recruitment, I mean, there is a dearth, certainly of neonatal consultants, and so much so that when they put the adverts out recently for two appointments, the one appointment was made straight away. The second one was found to maybe not be at consultant level. And so what the trustee would say, right, let's bring this person in, let's develop their skills and let's work with them because there is a dearth of skills. My understanding is that as far as, I can't answer the question about the international impact, but I know it's not huge numbers. The majority of our recruitment is our brand new midwives. So we can happily boast, certainly from UH&M, that all the midwives that qualified this year have chosen to stay with UH&M. And I think that's happened the first time in a long, long time. And they're starting to attract back some of those that went somewhere else when they first qualified, and they're coming back in. The recruitment numbers are in their single figures. They're still very, very important, but they're single digits. I don't think they're impacting, but we can certainly ask that question. Have I missed something else?
No, I was just asking about the skill mix within your workforce. You talked about filling vacancies, but my concern is that you need the appropriate skill mix to be able to deal with challenging circumstances.
Yeah, and you're absolutely right. I mean, just picking up again on Janice's point, you're absolutely right about we've got this influx of new midwives. And whilst that is wonderful, it will impact initially on the midwives that are already there, so we're mindful of that. Within the structure, there will be different skill sets, different requirements for midwives to be appointed to. Let me also just tell you though as well, with the Ockenden report, within the action plan, there were quite a few lines around the different skills that the different midwives should have, specialist skills. And I'm just going to go off piece a little bit. We've talked about the governance. There was a new document called the 3-year maternity and neonatal delivery plan that was launched in June. And as you can imagine, every trust has a whole heap of action plans and loads of actions. And what we've done is work with them to pull all those actions into one place. So from the 293 actions that UHM have got to deliver, I think about 100 of them are around workforce. And what we've done is we've pulled them all into one place. So there's a whole range of different skill sets that they have to specifically put in place to make sure they can deliver that whole range. And they are all going to be contained in that workforce action plan. So in response to your question, yes, there are lots of, obviously midwives have generic skills, but there are lots of specialist roles which they're going to have to train their staff for to be able to deliver the service and meet the Ockenden recommendations as well.
Lastly, can I just ask about inductions? That was easily an issue, a point of concern. Are there too many? Are there too few? What's the issue?
It goes back again to the workforce challenges, and there's no getting away from the fact there's been a real challenge with workforce. Induction to labour, and you know, as most people will know, the challenge you have, or the midwives will have, is, without teaching granny to suck eggs, they will have X amount of inductions. I'll jump back slightly. The guidance on when to induce women has changed. So the now recommendation is that they're induced 7 days post-delivery date. So that's impacting. So each day they'll have a list of mothers who are coming to that magic date and will need to be induced. So each day you'll have a list of, tomorrow there'll be 6, 7, 8. And of course what you can't account for is how many of them mothers come through the door or go into spontaneous delivery, and they will always have to take priority. So it's not a finite science, because you never quite know what's going to happen. So you've got the workforce challenge, you've got the challenge of not knowing what mothers are going to deliver. What we can say, though, is there's a process in place, an escalation process in place, led by Heather Johnston, who presented last year. And what that does is it supports a regional-wide response. So if, for example, in our area, we find today that we've got our induction of labours go up to 15, 16, they start to rise, there's an escalation policy that will say, that will give them a level, and at those different levels, they will then look externally for that mutual aid. So likes of Derby, likes of rural Wolverhampton, they'll turn to the partners and say, okay, can you take a mother? And the system will work, the region will work together to make sure those mothers get the safe, best care. Just to add a little bit to that, to help our awareness as well, we've got a mechanism called Shrewd, which is a digital, it's a dial, and it talks about things that happen in the ED, things that are discharges, so whoever's on call gets a picture of what's going on. We're going to get maternity and induction of labour added into that as well, so there's a real-time picture of what the numbers are looking like for our induction of labour, again, to help the system to respond appropriately and make sure the mothers get the safest care. Thank you.
Thank you. The paragraphs that Charlotte are referring to, and I think it's a really key point, are paragraphs 26 to 29 on pages 12 and 13. Can I just suggest that if members have got questions on that specific set of paragraphs, that we pick them up now so we take them as one? I will give members a bit of a lead into it, because I've got a couple of questions on this. First of all, specifically in relation to the neonatal mortality rates, which I think Charlotte accurately identifies is a concern. have we looked at any external auditing of the services versus the 3-year plan and versus Ockenden? Because previously I think we've done our own internal audits. So first of all, have we looked at some external audits to give ourselves some surety that there isn't anything more concerning in there? And certainly in terms of paragraph 29, which talks about the investigation into babies' deaths, how far back have you investigated and to try and find root cause and trends?
I think there's two answers there in the sense of there'll be the response from our providers and then there'll be ourselves. So from an ICB, we haven't done that piece of work yet because it still feels, it is shocking and the numbers are distressing and that's relatively new data to us, so we haven't. But the providers certainly are doing that work. So UHDB, we know, they had a review of the deaths we've talked about. We've got to, at the moment, I think, allow the providers to do their investigations, to do their audits, and certainly we can be asking for that if they're not doing it already, and take a guide really from what comes back from their internal investigations about what they're doing and how they're doing it. But certainly from an ICB, that's a recommendation we can take away.
Okay, and in terms of my second question, which related to how far back the investigations went, did you give me any thoughts in terms of that?
No, the UHDB one, I can't. I think it went back to 2021. I can confirm that. And there's the HCIB, the Investigation Bureau, have been involved with you. In fact, UHDB asked HCIB to do that piece of work to come in and look. Yeah, 2021, that goes back to. Yeah.
Thank you. I'm surprised it doesn't go further, in fairness, because I think we all share Charlotte's point, which is this is concerning, and I'm surprised there hasn't been sort of a wider time period. Can I just make a couple of points before I bring you back in, and then I want to bring in some other members who on this specific issue, and Baz wants to come in as well as Janice. I read the papers, and I felt like we'd gone back a couple of years, because normally we like to see a bit of data and a bit of, corroboratory evidence on all sorts of various things. And the papers seem to me to be very process-orientated rather than outcome-focused. And that I think I regret. And that may be my fault for not reading them in advance of getting them sent out, because they don't quite reflect what I was hoping to try and pull out. Having said that, this is a really useful conversation, so don't misread what I'm saying. But I think we've got to be really careful not to be, well, we've done the process, so we're all fine. If the outcome is wrong at the end of the process, then it was the wrong process, and we can't be too focused on the individual processes, in my view. It sounds like we have some joint concerns, and so I am surprised that the ICB isn't taking the data in front of them and saying, actually, we share the same concern. And particularly as a national backdrop, whether it's Shrewsbury and Telford, whether it's Nottingham, East Kent. I mean, there is Ockenden reviews going on all over the place. And principally, one of the issues seems to be the root cause is staffing. So it does surprise me that there isn't a bit more focus on this. Do you want to just come back on that point and I'll bring in some members?
Yeah, I think just to be mindful that the Embrace data then is very recent. So that's relatively new to us, so we are dealing with that. I think the other bit probably that I'm not playing out as well as I could is we have to be mindful that so every single death that happens, every single incident that happens will have a full investigation. There'll be a full root cause analysis. So please don't think there's complacency. There absolutely isn't. So those we'll be looking at internally all the time. We daily get reports sent in to us of, when things don't go right across the system. We get those daily. They get challenged at meetings all the time. So you're right, I'm probably being too broad and sweeping, but that detailed work is happening. going back to the paper, so the processing bit probably is my influence, and my apologies really. Certainly if you want the data, that is absolutely something we can give you. I think I was trying to give you a broader picture, which maybe hasn't quite hit the mark, I think, if that's, so apologies if that hasn't happened.
Just maybe that I'm detailed orientated rather than anything else. Baz, let me bring you in, because I think you wanted to come in on this subject, didn't you? Yeah.
I'm hoping I got this part right. It was to do with point 24 on page 12. I think you mentioned it earlier on about women being induced at a certain point. And it's just last week, Health Watch Stoke and Health Watch Stafford done a joint enter-in view at Royal Stoke Hospital. So we went in and spoke to those ladies on the ward and had an opportunity to really get that information, how they're finding things and more up-to-date experiences. And we are producing an enter-in view report, so that'll be out very soon for anybody. Just wanted to highlight a couple of things on there and not to make too many wide issues, just really narrow it down a little bit. One was that one of the ladies that it spoke to was 41 weeks and 1 day. But what the issues was that she was told she can't drive because she's now got too big, effectively, and it could be a risk. But at the same time, she had to come up from Penkhill up to Stoke, and there was a reason for why she was travelling up. But every day she was told to go back home and then come back the next day, and that was causing a lot of issues, having to get other people to support her. What was causing other issues was the fact that they couldn't transfer data from one trust to another trust. So there's lots of stuff about that by going. We don't quite figure out why that's the case, that one trust can't transfer to another trust. So just a couple of things there about this very topic. But one other question I have got, it was about the staff attitudes towards some of the other ladies in there. It was a mixed response. Some said they were great, but some said that they were treated quite badly or given really negative comments, left them quite fearful. So it's that. So I'll stop there for a second.
Nice to meet you, Baz.
Thank you.
So induction of labour, they are the hot topic. You know, it is a real challenge, and the staff have to work out each day how to keep each mother and baby safe. So certainly, you'll know from the CQC visit, you'll be familiar, Baz, that this is one of the areas they've had to look at. What they've had to introduce is checks, regular checks. So you're right, mothers are going beyond that 40 plus 7. And it's not ideal, it's not what anybody wants. And so they have to introduce checks where they're linking in with the mothers, they're making sure they're safe, and trying to keep the mum and baby as safe as possible within the constraints of the service they've got. So there's lots of work going on in that area. I'm hoping you're hearing that through because you're very involved in the ICB work. So I'm hoping you're getting some assurance from that. The bit about staffing, that's unacceptable and unpalatable. What we would hope is that we can garner those views. So Helen talked about the MNVP, the Maternal Neonatal Voices Partnership, again came out the Ockenden, and that was absolutely, wasn't it, about listening to the voices of mothers and their partners, listening to their experiences. Because we know there will be people who do step up and say, you know, this wasn't good, rightly so, and help us to fix it. But when you've gone through that process, it's really hard sometimes to go back and have your voice heard. So I'm really, really hoping that those, and I'm hoping to encourage those people who didn't have the best care to please come through our MNVP process, because we need to hear about this. Because, you know, I'm a nurse. There's no excuse for bad behaviour and how we treat people, and their perceptions are important. So all I would say is please encourage them to come forward and help to fix the issue if there are challenges.
Thank you. Baz, anything further?
It's just on that point about, you know, there's the concerns about, you know, the mortality rate and stuff like that, and it's very valid points that need to be high. But again, just wanted to drive that point home about behaviour and attitude. As much as it's about skills, there's knowledge, you know, people get trained, but they still need experience. It's about that, are they supervised regularly, what's going on? Because usually the cases we heard from these ladies, it's usually when they're in a room on a one-to-one with a particular midwife. And like, I'll give an example of one. One was told something in a particular way about, I'll have to get you some tissues, you're going to be crying. And she was left with this impression that she had lost a baby, to which when she questioned her, she said, oh no, you haven't. And it was very cheap. And this woman's response, you know, the pregnant woman's response was that was deliberate. I found that very, very deliberate, and it was personal. So it leaves a lot of people quite scarred. So, and the two engagement officers on the way out had to tell some of the midwives that there's a woman down the corridor actually in pain, can you sort that out? which they did get up and do it. But if they weren't there, what would have happened? So that's our concern about that behaviour, what's really going on. I'll stop there.
Karen, do you want to come back?
I do, because, you know, our job, when it was CCGs, now it's ICB, is to make sure that the delivery of services is of the highest quality. That's our job. And so, yes, we meet with our providers, we have really in-depth conversations, we see lots of data, we do visits, we do everything we possibly can to understand whether the service is as it should be. But then you will know, and that's where we find your organisation so valuable, is that we have to gather all the intelligence we can. So it's a bit like a lighthouse. We'll go this way to talk to the provider, what can you give us? We go this way to say, well, what can other folks tell us? We go in this direction to say, actually, what the people receiving the service telling us. So what you're providing is just as valuable as all the data that we get from our provider. But it's really important that we do gather this data to get a really good perspective of what the service is genuinely like. So again, I would say, I know you're very proactive, Baz, and I appreciate you attend a lot of our meetings in the ICB. So again, whatever you can give us and whatever we can provide with you to encourage those people to speak up, because that's just as important as the data that tells us that the provider is hitting a trajectory. But what is it really like? So yeah, the more we can get from you, the more reality checks we can get. Again, thank you for the work that you do, because it is appreciated. Thank you.
Thank you. I'm just going to continue to stick to these few paragraphs in terms of neonatal mortality, and I'm sure we'll come back to birthing trauma probably a bit later on in this session. Janice, did you want to come in on this area?
Yeah, I do, please. And the latter, those you've just mentioned, but later on in the meeting. I am somewhat reassured by what you've said about the detail that went in behind, in particular, item 29 in the report. This goes back to my earlier comment, is in the detail, basically. My original question, what actually is the West Midlands in 2021? You know, what areas are we bringing in? What specific hospitals are we bringing in? And for me, it's understanding that sort of level of detail, knowing, obviously, the awful events that have gone on recently, is being able to attribute it to that sort of granularity and detail. And originally I looked at that, was thinking, okay, we're trying to hide in some respects, and I'm using that word consciously, what is in the West Midlands. Is it hospitals that are within Staffordshire? Is it out of Staffordshire? But I think it's a case now, and I don't think it is hiding, by the way, that we are being able to say, okay, these are the hospitals, so we can flag earlier on where those flags are. Karen.
It's a practical element as well, isn't it? So it's neater in Stoke, isn't it? Because we've got UH&M, and it's in Staffordshire. You know, and I say this as a Lichfield person. You know, we go all over the shop, don't we? You know, we go to Birmingham, we go to Walsall, and there has to be a real practical element of how do we use our resources to get the information we need, but how do we use our partners? So we have responsibility for certain areas, don't we? So we have Stoke is our hospital, isn't it, for this area? But actually we know that, you know, in the south of the county, people don't go in that direction. But we do know there are systems and mechanisms set up to have those conversations, to capture that information. So for us, it's how we intelligently place ourselves to get the information we need. So I referred before about UHDB. Burton's in our patch, but obviously it's overseen by Derby and Derbyshire. So we work really, really close. I was a deputy chief nurse in Derbyshire prior to coming here, so we've got really good relationships with Derbyshire. We know we need to go to Wolverhampton, because of our 11,000 births last year, 800 of them were Wolverhampton. We have also got the challenges of Walsall, of UHB, and we have to be really pragmatic about how we use our resources to get the answers we can. And what we often do is we'll link in with the other commissioning, if we're allowed to use that term, commissioning organisations that work with those providers. So it has to be a really pragmatic, intelligent way of how we get assurance that every single mother and baby get the right care, knowing that we can't place somebody at every meeting in every area. It is a conundrum, Janice, no way two ways about it. So we do it in the best way we can, and through relationship building. We build really good relationships with those organisations like the other ICBs, to get a handle on what do we need to know about, what don't we, how are you doing your job. So it's a very pragmatic approach, essentially.
Janice.
Thank you for that. It is for me being able to look and say, okay, these are the actual hospitals. That data will be reported, no doubt. And I take your point completely. We're already asking very busy people to be able to report on that, but I think this is one of those areas where that actually trumps it. And knowing midwives myself, and one that's just qualified, that I have every admiration for what they do, having been through the other end of it as well, and knowing that babies do die and mums do die as well. How they then go back to do that and the support for those midwives thereafter is another story. But I think on this particular one, we do need to make sure that that attention and that reporting to that level of detail is being shared. Thank you.
Thank you. Did you want to come back, or should we take Keith's intervention here at this point?
Thank you, Chair. Not sure whether... well, I grew up in a family with 2 midwives of the old school, shall we say, going back times when they used to deliver 8,500 babies in a career, mostly at home as well. So, yeah, things have changed somewhat since then, and my concern is very similar to your concern to some extent. I see quite a lot of information in front of us, and I thank you very much for that. I had a quick look at the delivery plan as well as what you're trying to achieve to try and improve this current situation. But I don't think things have really moved on as much as I would have hoped to have moved on, particularly over the last 2 years. Now, I know that things have changed in terms of the structure of the whole NHS, so I know that's difficult, and we've had issues about borders, which we have every single subject we take on at this committee. It's all about borders. My concern is that the 4 themes that you seem to be looking at in terms of listening to women and then growing and developing sustainability and the safety, cultural safety, is all fine. The only issue I would say is that surely what we're talking about is the culture of safety here. That, to me, that should be the priority, not third on the list. Now, I know that comes after the other 2 elements which drive that. So I don't know whether that's the right way around for a start. But I'm just concerned that there are a lot of plans, there's a lot of conversations that are happening all the time. Do you have the resource to be able to deliver these plans that you've now looking at? I think that's my number 1 concern, to improve the safety over the coming years. And then how do we measure it? Because there's, again, there's no dashboard. The dashboard's sort of being developed at the same time and everything else. So it's not easy for us to understand what's going on. And then finally, I think my final comment is, as Baz has already suggested, and from my own personal experience, is that feedback from women that don't have a good experience is not something that I think is a natural way forward for many of the women themselves, because they see it as a negative. And a lot of them just want to forget about it. They don't want to be taken back through the whole experience again. So I think that many of the improvements that you are now looking at could be done by a far more sensitive way of looking at it on that number 1 priority list at the moment, which is listening to women in particular on the way back. So I won't go into more depth. I think there's enough questions for the time being. Thank you.
Karen, we're with you.
There's quite a few to get through there. So just to be really, really clear, excuse me, so those 4 themes have come out of the national policy. So the national policy, the 3-year maternity neonatal delivery plan that was launched in June, has said, right, we want you now to oversee and meet these 4 themes. So those 4 themes are ones that they've set. So they're not ours at all. It's a national one. What I would say is, when the midwives, I'm not a midwife, when the midwives saw the plan, there was a long wait for this plan. And if we're honest, I think there was a little bit of disappointment in what the plan looked like, because it hadn't got specifics. Working with it, though, and with those headings, actually, they work really well. They actually pick up all the stuff that we need to be looking at. But please be assured, those 4 aren't priorities. They're literally themes, and almost everything we do can fit neatly under those 4 themes. And you're right, theme 3 is around the culture, the safety. So all 4 themes have been worked on at the same time. We talked about, what was the next bit?
Resource to deliver services.
Yes.
Availability of resource was the second point that was made.
So the resources bit, there's two bits to that again. So it's providers are the folks that need to predominantly deliver on those 4 themes. So they need to have the resources to deliver the service. So those 4 themes are obviously a reflection of the service they deliver. And we do know they haven't had the resources. You know, if there's been one single challenge throughout all of this work, is the workforce challenge. It's a national challenge. It's very much a local challenge, certainly for us, UHNM and UHDB. Thankfully, really, we talk about, maybe I didn't flag it enough in here, but there's been some really phenomenal successes with their recruitment, which is coming into being now in October and November, accepting there's going to be that lag while the new midwives come up to speed. But there's been some phenomenal successes in the recruitment part. The other resource bit, though, is certainly within the ICB. We've recognised that we haven't got sufficient midwifery expertise. So we've got, there's a team, we've got 2 excellent experienced midwives, which I know you'll vouch for because they work really closely with you for the FNBU work. And of course our lead midwife, and of course Heather Johnston, our chief nurse. And the lead midwife for the ICB retired a few years ago and came back. And what we recognised, well, when she came back to a part-time, a half job, it wasn't enough hours. So we're actually interviewing on Friday for another 0.5 of a midwife in the ICB. So for the resources, you're absolutely right. For us to do the work we need to do, we need to employ more midwives to get out there and do stuff. 2 more points. Dashboard. So again, I think I've probably underplayed this paper, listening to the comments, because again, data is a real challenge. So we know that the national maternity data, there's tons and tons of it, but it's not collected in a way that is very usable, in the sense of, so I'm a mother, I'm going into a service, I might be captured at labour, I might be captured at antenatal, labour. So the data isn't clear on the numbers of who I am and where I am. I'm sure there are equations or whatever, but we don't know what they are. So the data's not the best. However, what we have done locally, and after 12 months of work, is we now have got quite a comprehensive dashboard, yes, for UHNM, but also for UHDB. So we always knew when Burton and Derby came together, they'd do their very best to keep the data separate. And true enough, they do. So we now do get data for our women that birth at Burton. And whilst you could argue they're not all going to be Staffordshire moms, the vast majority of them will be. Now that's happened in the last couple of months. So we'll now have one dashboard. Some of the metrics are slightly different because there clearly are data sets you have to have. And then you have the ability to put local KPIs in, key performance indicate. So we now have got a dashboard for the first time that has got UHNM. It has got the mothers at birth at Burton. Haven't got Wolverhampton yet, so we're working on that one. And the other bit about the MNVP again, you're absolutely right. And I go back to my point, you know, you have a baby, you've got through it. I mean, I would argue, having had 4 babies, that they're all traumatic. I don't know what a normal birth is. So you come out of this process, you're all going to be traumatised to a point. Not that I want to underplay the really serious stuff. What the MMVP does is, it then has a process to link in with as many mothers as it can and develop champions. So we're trying to get maternity champions who can then go out and link in with other mothers. And these could have had babies weeks, months ago. So it almost doesn't matter how long ago you had that baby. If you had an experience that you need to talk about, you need to share, we have that MMVP process that came out of Ockenden that says you need to recruit champions. We are, again this week, about to recruit our MMVP chair. So again, it's somebody independent of us who will come in and chair this work. And as I say, just give that slight independence and work with the champions to try. We need those mothers, we need the mothers and families' voices. It's a really key component of us getting a balance of what are the services like. So we were almost relaunching that piece of work.
Keith?
Yeah, very good. No, well answered all 4 or 5 parts. Well done. I just want to, on the dashboard side and also KPIs and things like these are the sort of things that we thrive on here, to be able to try and not to necessarily hold your feet to the fire or anything like that, but it's the idea of actually having something that we understand that can then translate back to try and improve safety and everything else, so we can then positively add into the equation ourselves. So I'm glad to hear that that will be the case. If you could maybe bring them back, that's something I don't know whether the chair wants to bring it up in future reports and things like that. The other thing I wanted to say is it within the community. I do think there's something here in terms of, I don't know what birth at home looks like these days or anything like that, but I know some mothers might still want to try and do that and all the rest of it without hopefully too many problems. So I'd be quite interested in knowing, would that take pressure off your hospital services and your maternity services a bit, or would it add to your pressure? How would that element help out? Because I know you haven't really mentioned it, but it has been looked at, and the idea of not necessarily delivering in hospitals is I know, going back to the 50s and 60s where my relatives were, so we say. Thank you.
Helen, we're with you.
Yes, so the home birthing service was temporarily closed from both providers at the beginning of COVID, and over the last couple of years has been reinstated, but then workforce challenges have meant that it's temporarily suspended again. With looking at the workforce and the recruitment that has gone on, obviously making sure that the staff are up to the skills to be able to work out in the community and to support those low-risk women who are eligible to have a home birth. So it does depend on the individual lady. It does depend upon the workforce being available and in place to support. So we do review that on a monthly basis through the local maternity and neonatal services board and ask for an update from each of the providers in terms of the workforce and the ability to reinstate those services, and both providers have indicated that they would be looking to potentially reinstate from Q4 of this financial year. So we are keeping track of that. So hopefully from April next year we would be looking at reinstating that home birthing service. We obviously, with all the challenges that we've talked about today, you know, we will monitor that through our mechanisms. We recognise that having the home birthing service is one of those three elements of choice for women. So having home birth, having a midwife-led birth or a consultant-led birth. But obviously, again, dependent on the individual circumstances and the ability to manage those deliveries safely.
Would that actually reduce the pressure, as I say, in the facilities and the services that you need to provide the hospitals?
In some respects, yes. But what we've seen is the complexity of women over the last few years has increased. So, it's hard to say.
Thank you. We're going to go back to the normal questioning. So, Bernard, you've been very patient, so we're with you.
Thank you, Chair. Keith has taken the majority of the emphasis I wanted to make on my points about safeguarding. But a couple of things, if I may. Where mums and mothers, English isn't their first language, are you certain that you are catching all of those people and making sure they understand the policy that you've shared with us today and how they're going to be cared for throughout their experience of giving birth? And the next point is related to the 4 bullet points that are in there, and safeguarding, developing a culture of safety. And I think maybe Charlotte or the chair mentioned it really. Having listened to what you've said, and there's been a wealth of information, and I thank you for that, but I don't get this sense of pace. Now, is that because you haven't got enough staff? And I would say to you that we're talking a lot today, and you've obviously got a grip, I would suggest, of everything that needs doing. But where's the pace on this? Because mums are giving birth every day of the week, and none of them want to experience what we've heard about. And what's given me an increasing level of assurance today is, and it hinges on the awful circumstances around Letby, where no one was listening. And I think you're telling us now that the communication strategies that are in place are ensuring that everyone is listened to and everyone gets a chance to challenge what's being done and what's being said. Is that right?
With you, Karen.
So if I go first and then Helen can fill the gaps. The first bit was about translation. So I won't comment on the FMBUs and home births, but certainly translation services for mothers and families. There is, I suppose I need to apologise in some ways that maybe the paper and the things we're talking about isn't giving you the assurance about the work that's going on. Certainly one of the things that we were told about just last month is a mechanism, I'm trying to describe how it is, the translation implementation that they're putting, jump back. So we know there's a lot of mums that will need translation services and families. So what they've just invested, as well as the usual translation services that you get, they've just invested in almost, it's a mobile, if you think of my laptop on a platform, there's a mobile piece of kit, if you like, that they're taking around with them that will support that direct translation. And you can get it on your apps as well. So they're using people, but they're also investing in as much technology as they can to make sure that they can get that translation service as accurate as possible. So it's a really important area, certainly for UH&M. They recognise the challenges of really understanding what mothers and families are saying. So they are investing in IT, and there's some really exciting, certainly IT applications that are being purchased and being trialled at the moment with mums. The other bit, safeguarding, that you touched on, and I was going to mention this anyway. One of the things that came out of the CQC visit at the start of the year was around safeguarding training. Excuse me. So you have children's safeguarding training and adults, and apologies if you know this, children and adult safeguarding training, and there's 3 levels to that. So they've always been aware of what they needed to do, the training the staff needed to undertake. But what came out of the CQC visit, actually, was safeguarding training for, adult safeguarding training for midwives at the highest level. And that was not something that had been talked about previously. So, again, the Trust have worked really hard to make sure that all the midwives get the appropriate safeguarding training. And my understanding is that certainly by the end of the year, all the midwives will have had that, which is quite an undertaking itself, because that needs input from external agencies. So that's one of the areas, certainly, that came up as unexpected that is being addressed. And again, going back to the Lucy Letby, which Thirlwell report, all I can say is that we are getting assurance that the trusts are taking this so seriously. If there was a midwife in the room now from the providers, I know what they were saying. I spoke with the Director of Midwifery for UH&M as the trial came to an end. And if I was to tell you that the devastation that the midwives felt at that response, I think they all felt it personally. Their profession has taken about, rightly, their profession has been down. They know the position they've got. They know how important, and the fact that one of their own has done this, I can't tell you the sense of devastation, loss that they felt in that department. And certainly what the Director of Midwifery spoke to me about was, do you know what, we need to take this on board, and we will take it on board. The bit we need to do first is deal with those emotions of all of our midwives. We've got to manage that, make sure they're okay, but absolutely then make sure that we've got all these processes in place. So we ask that question every single month. But again, it goes back to, I alluded to Tracy earlier, our Director of Corporate Governance, who is with us virtually. She will tell you about the work that's going on across the whole of the providers, across all services, to make sure the staff are listened to. If staff have any concerns about anything, maternity service, any services, they now need to be assured that they can speak up and be listened to. Have I missed anything?
Did you retouch on the sense of pace?
Yeah. Again, sense of pace, it is something that we've picked up on. It's something that we're talking to the Trust about. And I think certainly in the last 3 or 4 months, there has been a lot happening, not least because of needing to respond to the CQC. And I know Baz will be very aware of the work that's happening and the oversight of that from NHS England. What again I would say, and it's not an excuse at all, but there has to be a recognition that the workforce challenge has been enormous. The workforce challenge in all midwifery services, but certainly locally. That is now being addressed. But I wouldn't disagree with you. But I think certainly in the last few months, the pace has picked up. Again, for another layer of assurance, there's a monthly meeting, which is happening at the same time as we're having this, where certainly UHM are meeting with the ICB, with NHS England, with CQC, and there's a monthly meeting to get assurance about the response to the CQC report that came out in June. And at the moment, they are being commended by NHS England for the work they're doing. So I wouldn't disagree with you about the pace. I would say in the last 2 or 3 months, so there's been a terrific amount of work done. And just to hog the limelight a fraction longer, one of the areas that came out, and you can read the report, it's in the public domain, was around triage. So mothers presenting, to give birth, and having to wait more than that 15 minutes before being triaged. There's a new build, there's a new department being set up to allow mothers to come in, and there's eyes on them from the minute they come in, a purpose-built unit in response to that report that now makes sure that our mums appear, they are triaged, and they are viewed very quickly in a very obvious area, and there's eyes on them while they're waiting. So there's been a lot of work in the last few months, and again, probably I haven't done the service credit by putting some of that in the paper.
Thanks. Bernard, do you want to come back?
I'm grateful for that last update. Thank you. Could I just go back to when you were talking about the translation services, the laptop, the mobile phone? What if you lose the signal at the wrong time? Is there a risk there that they won't be able to see through their planned care because they couldn't access the Wi-Fi or something? Is that a risk?
So in place, the translation service has always been. So, there's access to physical people who can be those translators. So that system's there. It's been well established for many years, I would guess, in many of the providers who provide services to ethnic community groups. So that service is there. This is an enhanced service. So this is something extra. I think probably to give mothers and families more control. So they've got it within their gift. So this is an enhanced, it's going a step further to make sure that we provide every opportunity to have that discussion. Should I have handed over to you, Helen? Did you want to say anything about translation or? No. No, so this is an enhancement. It's building on, and I think it's giving people more control, making them feel more empowered. So they aren't necessarily having to go through a third person. There's probably a more immediate response to what they're trying to say.
Okay. Thank you, Chair.
Thanks a lot. Just following up Bernard's point, I think it would have been useful in this paper to have had what the key milestones going forwards are, because I don't think we have any visibility of that. There's lots of strands of activity and process, and it goes back to my previous point about the paper. It just misses some of those key outputs, because how do we hold you to account in 6-12 months' time? I don't have that. Now, maybe that was deliberate, or maybe that was my fault in not being very specific in terms of where the paper was trying to get to. And to pick up Keith's previous point in terms of coming back to this subject, I suggest we link it back into Janice's original first question, which related to the freestanding birthing units. And I suggest that, when we come to look back at that, and I think that was Helen's first answer, I think, when we come back to look at that, maybe that's the right time to bring this back so that we don't lose some of the strands of activity, because I think Charlotte rightly points out, there is a level of concern, and it's really trying to understand whether that is historic concern or going forwards concern. And I think that's the bit I'm not clear in my own mind where we are in that process. And I think that hits Bernard's point about speed or pace of delivery. I'm going to stick with first-time questioners and then come to those who've already asked questions. So, Richard.
Thank you, Chairman. Truly, I'm going to be naive in all of this in many ways, what I have read, but there's levels of concern, and Charlotte obviously has highlighted, I think, the number one concern. But I'm also concerned in terms of anxiety and mental health that comes across through the process. And it seems to me that perhaps we're not capturing that, and that does worry me, and you can probably say that I'm suffering anxiety, but it's not a laughing joke, and it probably extends as well to, the partner, and it can be from experience a traumatic time when you're told your wife is now going to have a C-section, and by the way, it's an emergency. It leaves you really in an open area of like, well, who's looking after me? And so I'm a bit concerned with that. I'm concerned as well with how data is collected and how it can then be managed to create a proper outcome. We can know what things are happening, and we can have conversations with Derbyshire, we can have conversations with the Black Country, etc. But this is Staffordshire, and Staffordshire, you know, we're representing Staffordshire people, and it's Staffordshire we want to really, you know, understand. And if we're not performing well, how are we going to get better on it and to ensure? You'll be aware that there are a tremendous amount of house build that is going on throughout the county. And surely that put pressures on that needs to be addressed as well. So I'm wondering whether you could perhaps give me some hope that those things could be addressed about, because it goes back to the Samuel Johnson. Lichfield in itself, and I represent a Lichfield division as well. Stafford wouldn't be a problem for my division, but it is a problem for Samuel Johnson, for actual Lichfield, which is immensely growing. And if you look at the type of house build, they're for young families that are going to be there. And so the numbers are going to increase naturally, yet your data is collated on perhaps through COVID and then non-COVID, etc. But actually, since COVID, we've seen our build really at pace. And I think, probably leading to Bernard's point, it's at pace we need to see some outcomes. Thank you, Chairman.
Let's canter through a lot of subjects, so who's going to start with those?
Sorry about that.
Karen.
Yeah, so start at the mental health one. So you'll know from the Ockenden report previously about birth trauma, about making sure that mums and families are safe. And we've had funding to support this. So there's a service that North Staffs Combined offer in the north, and there's a service that Midlands Partnership Foundation University NHS Trust offer in the south. And this is exactly for birth trauma, it's for mothers, it's for families. And so that service is being provided, and we monitor that service, we have updates on that service. In fact, we had a very thorough review of it in October. They came to our meeting, talked about the numbers, talked about the work that's happening, how they're supporting. So that service is there, and that's in place. The other bit that I think Heather will have spoken to you about last year was another Ockenden recommendation, was appointing a maternity and neonatal independent senior advocate, Manissa. And this was precisely that. It's someone who's independent, it's someone who doesn't work in our system, outside our area, is not contaminated, for want of a better word, with any of our services, who will be that person who comes and links and works with mothers, families who have been through that trauma, who need that support. So we have been really fortunate to appoint a lady called Melanie Mears, and she was appointed in July. And she actually worked at East Kent Hospital, so she comes with lots and lots of experience and lots of knowledge. And she's actually, her speciality is neonates, so it's a really valuable attribute to our team. So she came in place in the summer as this Manissa, as part of a pilot that we're involved in to provide that service. So nationally, what they've realised, though, is when they put the Manissa role out there, they weren't too sure what they asked for. They're not quite sure how it should work. So there's a pause at the moment in that programme before they actually launch it. But how we're very, very lucky is that because of Mel's knowledge and experience, she's been selected for the national steering group. So she's bringing all her maternity and all her neonatal knowledge and working with the national team to develop and support documentation policies about how this Manissa role will work. So we're hoping that will properly launch imminently. And so she will be that person who works closely with those mothers and with those families who have been traumatised, who need that extra support. And that's an absolutely dedicated post that's not involved in any of the local services, so can look with fresh eyes and be independent. So we're very excited about that, and we're just waiting now for her to be able to impact, essentially. The other bit then, so data collection. So I'm a detail person. I love my numbers. It's a bit weird for a nurse, but I do. So apologies again if I've undersold that. But it goes back to the point, I think, in response to Baz. Our job is to take absolutely everything we can lay our hands on, all the jigsaw pieces, and put them together so we get a picture of the services that are being delivered. And one of the things, again, I probably haven't spoken about, which I think you've picked up on, is give us the data, give us the voices, but actually it's also putting ourselves in places in Staffordshire. So we will go and we will do visits. So I've been doing clinical quality visits for 10, 15 years. You know, I'm not a midwife, but if I step into a hospital environment, within about 30 seconds, I get a sense of how the staff are, how the world is, and we do that. So again, another thing we do is to put ourselves in positions in Staffordshire, provisions of care, to get a feel for how the world is. We do visits. So there's lots of activities we do in Staffordshire to get a real feel and a handle on what a service is really like for the people that live here. We take every opportunity we can. I know we did an Ockenden insight visit to UH&M in September, and we join with the visits that go to Burton. So we take every opportunity we possibly can, which again I've probably underplayed in the letter. And the bit I can't comment on is, the housing bit. Thank you, Helen.
So as part of the workforce review and the complexity that we've talked about in terms of the levels of complexity in terms of low, medium and high risk women, we look at demographic information in terms of those people that we see now, what we think those projections are likely to be going forward in terms of demographic and non-demographic growth. So there's a lot of information that we receive from our planning team to support that, linking in with the information from the local authorities as well in terms of the really useful reports. Looking at the information in terms of the people that were using the service beforehand, but those who may be eligible if we were to reinstate services, who would use them. So we know that previously there was a cohort of women that used Stafford, there was a cohort that used Lichfield. We were able to see where those people came from and the types of characteristics that they had. But what we have to do is to make sure that we've got the workforce that matches that. So just because we've got a set of housing that has younger families, etc., we don't know what that level of complexity would be when they come to give birth and what their pregnancy journey will be. So what we do is we monitor that with the teams so that then they can look at those workforce numbers, and there are key ratios in terms of the numbers of women that the midwives to birth mother ratios in terms of how many midwives you would have for a low risk unit, medium and high risk. So that is monitored by the providers and by us on a regular basis. We will assess that, and as we go through the service change process, that will all be taken into account and looked at. So we recognise that there are areas of growth, and we know that that comes up in a number of our conversations with yourselves, but it is something that we look at. But within maternity, we need to look at those different elements of risk and how we manage that workforce.
Thank you. Richard? Okay. I've got a couple of other speakers who want to come back, so I'm going to guillotine the debate after that. So Anne first, briefly, please.
Thank you very much. Yes, you mentioned in your presentation just about housing and mums that's probably living in a damp house or mold. You know, do you have any person working with housing providers? You know, if you're concerned about a mum that's pregnant and living in a housing situation that you don't adhere to. I just wondered that. And secondly, I'm good to hear about the triage system, because having not myself personally having an impact on the maternity services at UHNM in the last 12 months, but having to sit on those chairs for 5 hours, sitting in a maternity waiting for your granddaughter to be triaged, I'll tell you what, it is not. So I'm really pleased to hear that you've done something about that. Post-trauma, actually, I mean, I've got to say, speaking from personal experience, she had to have 3 days in hospital, and when the baby was born, that was fine. Absolutely, I cannot fault the services. In room 10 on the 21st of December last year, it was absolutely perfect. Really looked after. But after that, she had 3 days in hospital. The baby was looked after fine, but she was really commenting on she was not taken seriously about the things that she was asking for and what have you. So that is something I hope that has been addressed. And thank you very much, Chairman. I just wanted to comment on those.
Can you reply in general rather than about specific cases? Because I think Anne's point is well made and useful, but obviously we don't comment through this committee on individual cases.
I can't comment on the housing, I'm really sorry, but I can take that back. I think if a midwife was sitting here, they might be able to comment, to be fair, but we can certainly take that back.
Sorry, Chairman, I'm just concerned about if any mums living in a situation, they might be on their own because the partner's left them or whatever, that their situation is looked at to make sure that the baby and the mum are fine. Thank you.
And actually, I've got a route in now, haven't I? Because that infant mortality group we talked about, that report and the steering group are absolutely going to be looking at this. So that is something I will take back, because in order to address, mum's preconception, they're going to have to do that work. So I can certainly get assurance about how they're going to do that. Triage, they have got some lovely seats. We did look at them, so you're fine. Couple of bits about the trauma. So what I would say is actually, if your daughter lives in the area, please encourage her to be a champion. And the bit I didn't pick up on before, and it was in the question for the gentleman earlier, apologies, you talked about fathers. I didn't answer that question. Again, I go back to my point, I think every labour's traumatic. They just, I think that's why women talk about the labours every time they get together, 30 years later. It's traumatising. And for fathers, it's So just the bit I didn't pick up on about the father bit was, the Champions is open to fathers as well. So much so that when we have a patient voice at the start of our LMS partnership board every month, we have someone come forward to talk about their experience, good, bad and indifferent. And I think September, October, we had a gentleman come forward, we had a father come forward and talk about his experience of the birth. So it's just about, I realised in the questions previously, I missed that bit out. That, fathers are offered the opportunity to be champions, but I would encourage your daughter, to please have a voice, talk about the good and talk about the not so good, because you need to try and fix it. So, yes, please, if you get a chance, please encourage her.
Thank you. You don't want to come back? No, that's okay. Keith, did you have anything further? No, that's fine. Baz, did you have anything further? No? Okay. So I think that leaves us with Janice.
Thank you very much, Chair. It's on the birth trauma side of things that I'm quite keen to get a bit more information from what you've already said as well. So just to go back a little bit, following the publication of the Women's Health Strategy, this committee established a working group for women's health in particular. And whilst maternity isn't part of that, as the chair of the group, I have recently had some contact with Theo Clark, obviously Stafford MP, who has made an all-party parliamentary group specifically for birth trauma. So it seems opportune that whilst we've got part of this report on there, that we make those links. As far as the content here, I can see that we've made a fantastic appointment locally, on item 15 in particular, but then it goes on to mention about elsewhere it's being banded differently. And I just wanted to try and look at how we can make sure that there's a consistency in what we're trying to achieve on there. And then secondly is maybe to give us a bit more detail into how women and families are supported following the experience in a traumatic episode. And I think you're right, there are different levels of trauma that might be experienced at that time. And lastly, you'd mentioned about some of that being paused for the time being, and it was given a set period of time of 12 months. Is that likely to be extended for again a set period, or is it something that is likely to then become embedded as far as how we are trying to support women and families after they've had that birth trauma in particular? Thank you very much, Chair.
Karen.
So the women's health strategy sounds really exciting. And, you know, whoever can be involved in that, please just reach out and whatever we need to do to support that. The trauma support, there's so many different levels. So if you think about the most traumatic, there's a really strong bereavement service. And I know we did a visit recently with, you know, every provider is expected to have a strong bereavement service, as you would expect. And I think wherever you go, you know, that will be a strong area. There's a terrific amount of compassion. You know, I know the day we visited the trust, there'd just been a bereavement, and I'm not a midwife, so I've not been so I found even being in that building with someone who'd lost a baby is incomprehensible. And that is not underestimated by any of the midwives. So I think, to be fair, you'll find really good bereavement services. I know certainly Derby does them, I certainly know UHM do. So that bit, if you like, is kind of taken care of. I think it's the other bits that we're trying to pull the strands in on. So, you know, I know the trauma bit is a challenge. So we know we've got the Lotus services, and they are there for north and south of the area. The Manissa, the role, I mean, she will be superb because she's lived and breathed, and we are so lucky to have her. If I talk about the banding, but just being a little bit mindful, what I do know is that we were fortunate to appoint a senior person. She was a matron. It's an 8B role, which is a senior role. She's got bags of experience. We are really lucky. I don't think other areas of the country have necessarily appointed to that same band, maybe because they haven't been able to find the people. There's this workforce issue, isn't there? There's a dearth of them. So there will be areas that maybe haven't been able to appoint to the same band. People won't have been able to appoint to someone as experienced as our person. And I think with the ambition of being independent, the ask was that you get somebody who can be compassionate, empathetic. They didn't necessarily have to be a midwife. But that was to maintain that independence, to try and give fresh eyes. But I wonder now whether, looking at the challenge of that role, because it will be, you know, emotionally that's going to be a really challenging role. I think the national team will take a step back to say, actually, is what we've got what we need? Again, I go back to the point, we've been exceptionally lucky or good appointment by our lead midwife, because Mel is very, very good. So I have every confidence that she really is influencing the national picture with all her knowledge. And as soon, she's making inroads, she's making connections with all the providers in the area and just outside the area. So as soon as the push button goes, I'm confident that she'll be able to provide the service that we need. And make sure that she only provides the service we need and doesn't interfere or step on toes with other services that are already going on. Has that answered your question?
Yeah, it was about the consistency, knowing that there would be that sort of variation in the level of experience potentially, how it would be consistent, and also with regards to the time frame, knowing that it's paused, it was 12 months, what's the sort of longevity?
I spotted that last bullet point as I came off. You're absolutely right. So the funding is for 12 months, and it was supposed to be from 1st of April to 31st of March. Now, we went early. We've got our Manissa in, I say that in the summer. Some people are still appointed or will appoint them. So even given that, we've only used 9 months. So NHS England have said again that, yes, we'll get the 12 months, but also there's an absolute push to get at least another 12 months as well, to give us some consistency. So yeah, we have that sure. I think again they're waiting for it to be rubber stamped, but there's certainly a push to get an additional 12 months as well.
Thank you, Janice. Just to wrap up this morning's session in terms of birthing trauma, Obviously, I'm aware that all hospitals nationally have received some additional funding in terms of birthing trauma, which I think has come from the Secretary of State for Health, following the campaign that Janice referred to by Theo Clark. You mentioned this review that's been undertaken in terms of birthing trauma locally, which was undertaken in October. Will you publish that or share that with committee? Because I think we'd be interested to understand that. And I think the points that Baz made in terms of hearing the voice of mum and baby is really critical as part of that. And I'm assuming that is a key element within the review that's been undertaken.
Is the review referring to the one at UHDB? Is that the...
It was the one you referred to, and I just wrote it down. So either I wrote it down wrongly or heard it wrongly or misunderstood what you'd said. Have I put words in your mouth that there hasn't been a review?
So there's two reviews, sorry. There's a review of the Manissa role that's going on now, and then there's a review that UHDB voluntarily asked for of their deaths. And I'm not sure whether that will be published or not, if I'm honest.
It was specifically related to birthing trauma. It was said about 10 minutes ago. Maybe we need to watch this back and just come back to you with the exact specific bit. I thought you were inferring there had been a review undertaken of those who'd suffered significant birthing trauma and had raised that. You're now not saying that's the case, so maybe that was my understanding.
I think it was a review of the Manissa role and the pilot project.
Okay, understand that. Okay, on that basis, I think we will take the opportunity to finish that debate. It's not often a debate goes on for 90 minutes. And I think what it demonstrates is, A, it's an emotive subject, but equally that it's an important one for our residents, particularly as, if you get birth right, then you've got the rest of your life ahead of you. We should pay tribute to the people who are working within maternity services, because clearly it's not an easy area, particularly with the more complexity that you talk about, and particularly with some of the recruitment issues. But also we should just note, and it's not probably as strongly as in the report as I'm aware of, having spoken to Tracy Bullock over at UH&M, there has been quite success at recruiting into midwifery services, bearing in mind every place in the country is asking for the same thing. I think today's debate demonstrates its work in progress, and on that basis I'm sure members would want to bring this subject back, maybe alongside the discussion on freestanding birthing units, because my understanding clearly is that these are temporarily closed at Samuel Johnson and at Stafford, subject to getting the right levels of staff and subject to them being trained. And unless that changes in terms of the nuance of that, then I think we should keep that on our radar. Otherwise, I would thank you for what you've contributed to this morning's debate. I'm just going to check committee are happy with that as a set of actions and recommendations and proposals. Am I getting enough nods around the chamber, Charlotte? Okay, I didn't get much from that. Let's see. Everyone else? Yep. Okay. So we will do that. Thank you for coming. You're welcome to stay. You're welcome to go. Otherwise, we're going to move on to item number 6, and we're with Paul Brown online. So good morning, Paul. Sorry to leave you for so long. I think you can assume that we've read the papers. Maybe not inwardly digested every nuance in the papers, because there's a lot in there. But if you want maybe 5 or 10 minutes, maybe 5 or 7 minutes just to talk us through if there's anything specifically you want to highlight.
Great, thank you, Chair. Thank you for having me back. And sorry I can't be there in person. I had intended to, actually, but my diary's gone a bit mad for today, so I couldn't do that. Yeah, just a few words of introduction. So when we talk through the operating plan for the year ahead, you asked for these updates. So it'd be useful to have any feedback on whether this is about the right sort of length. As you appreciate, we're dealing with huge range of different things and trying to keep it as simple as we can, but at the same time making sure it's comprehensive. There are a few exceptions which I'll probably dive into, but first wanted just to mention we call it the placemat. It's on page 27 of the bundle of 46, assuming it's in the same order as yours is as mine, of the PDF for this meeting. I think it's quite helpful to look at that, because often we do focus in on the things that are going wrong through escalation. That's the right thing to do, but it's important also just to note there is quite a lot of progress too. So it's not all doom and gloom. There's lots of progress on some of the children and young people area that you'll see there. Quite a bit of progress on mental health, learning disabilities, also primary care, end of life, and some progress in some of the planned care areas. But I guess the focus for today needs to be focused in on those areas where there's more to do. We've escalated this month 4 things that we've really been focusing in on. The first is the whole area of urgent care, which we felt we were making quite a bit of progress over the summer. The last few months have been extremely difficult, very short term. The last few weeks have been even more difficult. So it's not in a great place. But we talked last time about the single focus, or a focus on one single thing, which is around the waiting time for patients for Category 2 and Category 3 ambulance wait. At Category 1, we know are the cases that get picked up pretty quickly, but Category 2 and Category 3, where we were seeing the huge delays of last year. And again, we actually saw sort of a good start to this one, actually, but of late it's just tailed off, the improvements tailed off. So, Chair, we were focusing in through the recovery plan, which I'll come on to in a second about the money side, but the element of the recovery plan is really focused in on the over 75-year-old cohort, because we know in that cohort there's a kind of disproportionate use of acute care. You'd expect it because older people are more likely to require acute care. But we also know that in many cases that is not necessarily what people want, particularly those coming up towards the end of their life. And so we are focusing in on this. And whilst we're not seeing the results of the numbers before you, I think we've got lots of evidence now that some of the recovery elements that we're working on are really starting to gain traction. We're focusing in on, particularly on care homes, where a number of older people, frail people reside. And we've got lots of evidence now that sometimes patients are sent from the care home into A&E, which doesn't result in an improvement in their care, often to the extent they actually die, and they make that journey and then they die, and that's quite possibly not the right thing for those people. So we are focusing in on that now. And whilst I haven't got evidence for you that it's worked yet, I do have evidence that we've got some really strong schemes, and your Richard Harling is leading this piece of work for us in the care homes. And we're very optimistic that that's going to make a big difference to this going forward, particularly the Category 2, Category 3 waste, because often patients in those categories are the patients who we can do something else with. We can avoid that acute admission in the first place, and that's really where we're focused. So the area of urgent care continues to be a pressure point. We've touched on the area of serious mental illness, where the number of physical health checks that cohort of patients are receiving is not at the level that we wish it to be, and so we're focusing in on that to really get a grip of that, and that's a piece of work underway at the moment. That's the second area. The third area is the whole area of elective care. A bit of a mixed bag with elective care. The industrial action has really made it very, very difficult, because we've lost a huge number of days. Each time you lose a day, it's not just the day itself, it's the run into the day, and then after the day it's going back through the list, because the whole thing's kind of been put out. So that's really affected delivery, but the underlying activity that we're delivering to people waiting on waiting lists is actually going up. So we're doing quite well on that, and that's in that regard. Again, it's still not coming through in terms of the numbers of patients waiting, but we think that's largely driven by the industrial action, as opposed to it being the underlying provision of care for people who are waiting. So we've had a few weeks now without industrial action. We've just got our fingers crossed that would continue, and hopefully the issues will get resolved, because we do now have that underlying level of activity, which means that we will start to now reduce the waiting list, the length of time and the numbers of people waiting, if we can just have that sort of long running now of activity without industrial action. And then the fourth area, Chair, of escalation is around the money. We're having a very difficult year. We knew it was going to be really challenging. We created a plan which we called a kind of a best case plan, in the sense of it required a number of assumptions to go our way. Unfortunately, we haven't seen that happen. We've had, and I know you have in local authorities too, we've had significant price inflation impact. For us, it's amounted to about 50 million of costs that we haven't been funded for, and that's the main driver for our in-year position, which is a deficit. We are required by NHS regulations to forecast formally a break even, but we've been saying to the centre now for a few months that we can't do it. We submitted again last week and told them we couldn't do it, and we were told that wasn't good enough. So we've been asked to go back again round the houses, which we're doing today, which is why I'm not with you, to resubmit. We just don't think, unfortunately, we can get to break even as a system. So 3 years of break even, which have been good. Unfortunately, this year we are going to miss the target. We are therefore, well, looking firstly to reduce the level of the deficit as much as we possibly can, but it's extremely difficult with that level of inflation, and on top of that, the demands, as we were referring to earlier, just absolutely very, very acute. We do have extra beds open, extra primary care capacity in place, and we've taken the view as a system that clinical safety is paramount, and clearly we're intending to achieve our financial targets, but not at the expense of safety, and that's driven our deficit. That's all quite doom and gloom. There is some good news though amongst it all. So as a system, we've agreed to focus the recovery plan, which I mentioned before, on essentially on one thing, which is continuing healthcare, where we know that we're a major outlier. So we spend about £100 million more as a system than our capita would suggest for every other system in the country. We're a real outlier, and importantly, with this area, we know that it's not resulting in better care. It's not that we're providing more CHC and it's good for people. It's kind of the opposite, really, that we're over prescribing care, and it's resulting in some cases, patients having the end of their life determined by high levels of intervention, which isn't what they want. So we have been focusing on that, and that's why I mentioned before the over 75-year-old cohort. And some really encouraging signs. We're working now really strongly as a system across the ICB with the providers, and importantly with the two local authorities. And it really is starting to work. So we've now achieved in-year financial impact benefits of 10.6 million, which, as I say, is actually making patients better as well as saving money. And that equates to a full year effect of 31.9 million. And we are still only just about a bit over a third of the way through the CHC caseload. So we actually feel currently we're on track to get somewhere close to hopefully that 100 million figure that we are an outlier by. So we don't know where we're going to end up, but we are certainly making good progress, and that 32 million will play into next year's position, which will relatively make our position better, but clearly it gets the backdrop of some really, really difficult financial outlooks for the whole of the public sector, but the health service and I know local authorities too, as a result of the autumn statement. So I'll probably stop there, Chair, and take any questions.
Thank you, Paul. I'm not seeing any early indications, so I'm going to kick... I've seen Anne Angela.
Thank you very much, Chairman. There's a lot in here about general practices and primary care. I just wonder what the ICB's thoughts are moving forward with the patient participation group. Do you take any notice of what these groups are saying, or, where do they sit with the ICB? Thank you.
Yeah, that's massively important. And Tracy's on the line, and it's more of it in her bag. So perhaps if that's okay, Chair, I'd ask Tracy to pick up that one.
Perfect. Thank you. Good morning, Tracy.
Hello, good morning, committee. And apologies, I'm on my phone because the chair knows I've had problems overnight, but also I've got power cuts at home. So I hope you can see me and hear me okay. Yeah. Thank you, Councillor Edgeler. PPGs are a really important part of the information and intelligence that we gather. They do send us information very much more about just the practice and the people that attend the practice and the general practice, the way the general practice works. So we have looked at our People and Communities Assembly and how we speak to our public, and PPGs are part of that element. So yes, we do encourage each general practice to have a PPG. It is for them to sort and organise, but we will support general practice if they are struggling or they need support with their PPGs, and we have toolkits and things we can do to do that, because we recognise the valuable contributions that they do make.
Anne?
Thank you very much, Chair. Can I just also ask, moving forward, again with mental health, there's a lot in here about mental health. Are we giving as much input financially in that we possibly can to help people? I know everything comes down to money at the end of the day. So are we giving as much help as that and input into mental health as we possibly can? Thank you.
Yes, thank you for that question. If I can take that one. Yes, absolutely. There's a thing you may have heard of called the Mental Health Investment Standard, which was created by the NHS, which was in response, really, I suppose, to decades of relative underinvestment in mental health and care for mental health people. And so we do abide by that, and that basically means that a greater share of resources each year go into mental health vis-a-vis other services. So mental health has been, whilst other services are unfortunately seeing flat or reducing money, mental health has seen an increase, rightly so, because it's underinvested service. So yeah, we have been investing in mental health, and there's a collaborative which works across the whole system, which essentially leads to a system agreement about where to invest that resource.
Thank you, Paul. Richard.
Thank you. I'm looking at page 5, the overview of key underpinning deliverables, and I tend to see that we see a number of behind plan and no mitigations identified. Are you obviously treating that as a priority, and what kind of timescale are you looking at? Because it is concerning that certainly some of the areas that are highlighted in red, and equally those that are in the yellow, the deliverable behind plan, whilst you then accept that there are mitigations in place. And I just question the try and improve the position. I wonder about that word try. I would like to think that you were not looking at trying to, but you were actually going to improve, to be honest, because it affects us all indirectly with the areas of concern. And obviously, we've got some greens, which is good. That they're on track, but obviously it would be nice to see, or it might be an open-ended question, when do you envisage to say blues in terms of complete?
Whole range of questions there.
Yeah, and it's a very fair challenge. The thing is, with this, we've got to be realistic about what we can do, and so whilst, for example, one of the red ones is to eliminate the numbers of patients waiting 65 weeks by the end of March. That is the requirement upon us. We physically can't do it if industrial action continues. It's just unfortunately impossible. Which I suppose isn't a great answer, but that's just the truth of it. And I guess with this, we're trying to be honest and straight about there are some things that we just aren't going to be able to do for whatever reason, whether it's lack of resources or it's lack of staff or whatever the cause may be. You're right though about the language. Try to improve isn't strong enough, is it? So I will take that away in terms of the way that this is portrayed. But I guess in the current climate where we don't have resources we need, frankly, we don't have the staff that we need. We have increasing demand on our services. We actually cannot do everything, is the truth of it. We want to be honest in our reporting, and where we can't do something, we want to be honest and say that is the case. But as I say, I do take the challenge on board. We need to be clear why, if that is the case, why it is the case, and at the very least to do as well as we possibly can, rather than just kind of, as you could take from this, it suggests we just kind of give up, we can't do it. So thank you for the question. But as I say, where it's red is because we're not going to get there. But that's helpful feedback. Thank you.
Richard, do you want to come back?
Well, simply to come back that obviously, I thank you for your candid response, because obviously the element of truth is there that in terms of resources and so forth, would say that there is a problem. That obviously is something that he obviously needs to take back, and I suppose other politicians need to wake up, maybe, in view of ensuring that they're resourced. Thank you.
Thank you. Let me bring Charlotte in.
Thank you, Chair. Thank you for the report. What I think the report doesn't do is to identify the patient misery that this identifies. To take an example, Children and Young People Community Mental Health talks about currently below Q2 plan by 10.8%. But I'm getting letters telling me that the wait for CAMS for an individual, for a young person, is 2 years. You know, those figures don't really give me an idea of what this means on the ground for patients, the people that we represent. And I mean, I don't know, maybe the waiting list is not 2 years for CAMS, but if it is, I'm very surprised that it's not identified as a red indicator on your summary chart, because it seems to me that young person's mental health has to be a priority, and despite what you said to Councillor Edgeler, I don't actually believe that there is parity of esteem or parity of investment in physical and mental health.
Paul, with you.
Okay, thank you. And again, a very fair challenge. So we have indicated kind of red on the waiting list position. That's a very general one. You're making a specific point about CAMS, and you're making it powerfully, and you're completely right. Nobody could defend people having to wait that long for an assessment. We can obviously provide the detail, but we're then into, because there's probably hundreds of different waiting lists that we could provide. So it's about the detail that you would want. We can pick at that one specifically, if that's helpful, Chair, and come back with some specific actions that we're taking around CAMS. That probably is a better action than, because otherwise we end up producing a report which has thousands of pages, which I don't think is what you want. So if that's perhaps the best solution, is that we take that one away and come back next time with a particular report on CAMS.
Okay, thank you.
Sorry, let's pick up that suggestion. Is the rest of the committee in support of getting a special report on CAMS, which is what Paul suggested in response to Charlotte? Yeah, okay, so we're all in agreement with that, Paul, so yes, please. Thank you. Anything further, Charlotte? Are you happy for us to move on to Keith?
Thank you, Chair. Obviously, I dare say you're fairly disappointed yourself with what's been happening in terms of being able to achieve any of the objectives that you put down here, and it's quite honest, there's quite a lot of things that you've got some idea of mitigation on, but others not. Obviously, you've mentioned that already. In terms of the efficiency programme and the slippage of that, in terms of the over-budget that seems to be happening at the moment as well, do you see any way out of the current situation to be able to get the efficiency programme slightly better onto track, particularly in the latter half of this year and early next year, or whatever, to try and get things moving a bit? Because obviously I realise that inflation hasn't helped, and the biggest thing is about the cost of prescribing costs and things like that seems to have skyrocketed over the first 6 months. Are there any plans in place at the moment to try and reduce those costs? I mean, it's not necessarily in your control, but to try and get things back into a better, where we can maybe, as said earlier, a few more of the blue dots and green dots can be sort of implicated. I don't really want to be too negative about it, because obviously it's a difficult situation with the industrial action ongoing as well. So I just wondered if you're working on a sort of a supportive programme to try and produce something that makes more sense for all of us later in the year, hopefully after the industrial action has been rectified. Thank you.
Paul, we're with you.
Okay, thank you. Again, a very good question. So actually, in terms of efficiency, we've done quite well, which might sound strange given the financial position, but we actually have. So we set up an efficiency target for the year of 181 million, which for us was 7.2% of turnover, which is the highest the system has ever attempted. And at the point of this report, we'd got to 150 million of that, so 30 million to go. And since the report, we've actually made some further progress, and we actually think we're going to get pretty much up to the level of 180 million at year end. So in that sense, we've done well. Unfortunately, that's not been enough because of the inflationary impact that I mentioned, and also just the NHS, because it's so constrained now. Some of the allocations that we're expecting haven't come through, so that's taken us off course. So I wouldn't say it's not our fault. I wouldn't say that, because we're responsible for delivering services within a cash envelope. That's our job. So yes, I am disappointed we haven't done that. But by way of mitigation, we've done well on efficiency. It's just not been enough. So you're right. We're having to think about kind of where we go from here. And taking cash out of the NHS is extremely difficult. I mean, it is for local authorities too, but we spend about 75% of our money on people, and you won't find many people who we've got who we don't really need in some way. So to save money cash out of the system, we do have to have fewer people. That's the only solution, unfortunately. One of the things we're looking at is productivity. And I think this is a challenge from the regulators to us, and it is a fair challenge, which is that over the COVID periods, we increased the number of people that we employ, and that's continued actually since COVID. So we do now have larger workforce than before, but in terms of kind of the headline numbers of patients being treated, it's not gone up by the same proportion as the staffing. So therefore, the charge to us, and it's not just a Staffordshire problem, it's a national one, is that productivity has fallen. So that's really our focus now, is how can we regain productivity? How can we move patients through the pathway appropriately for the patient, but in a more effective way, so that we're not seeing the delays in each point along the pathway, whether that's in the primary care, in the GP surgery, or if it's an A&E, or if it's discharge from the bed. And we're looking at that whole pathway piece, and that's really, I guess, where we think there is some light at the end of the tunnel for us, because we know, I mentioned CHC, and that's a consequence. CHC is a consequence of the pathway not working optimally. So patients are not optimised, don't go home, and because of that, they require CHC. So we're looking to change that, and by having a system focus on this one thing, because it can't be fixed by any one organisation within the system. It is literally a whole system solution that's needed. We are starting to see the benefit, and in that sense, I'm optimistic. I'm optimistic that we've got people pulling together. It's just incredibly difficult right now. There just isn't enough money. But given that, we are looking at the art of the possible of what we have, and we can make the money go further. So I'm both a mixture of disappointed, which is your question, but also optimistic that we're doing the right things. And that's where we are, and that's what moving into the new year. We need to maintain and increase the pace of that.
Keith?
Yeah, I didn't want to try and concentrate too much on the negativity because of the environment which you find yourselves in. I mean, I don't think much of it's necessarily of your making. I'm just wondering whether or not you would wish to reassess maybe some of the targets a bit more realistically for the second part of the year, or on an ongoing process, rather than trying to stick to what you're now saying is basically targets that you can't necessarily reach, or at least some objectives within your plan that you can. Or do you just want to make sure that people are aware that you've had this plan when all the CCGs have become one? I don't know where you want to go from here. I think that was the question. What do you think you need to try and do to make it a bit more realistic about what things you can try and get done over the time period you got, which is not long, to be honest, is it? So. Yeah.
So I think thank you for that recognition. In terms of the financial position, no, we can't get the position back on track. It's just not possible. But in year, but it is possible in the medium term. In terms of the kind of the red circles where we're behind, we want to continue to try and achieve those things. Those are things we need to try and achieve. Yes, you're right. We need to be realistic about what can be done, and so just saying we're not going to achieve it isn't good enough. But maybe getting closer to the target. So again, helpful feedback. We need a plan for the second half of the year, which is to recover those things that we can recover, even if not in its entirety, get as close as we possibly can to the aim.
Let me bring in Philip Atkins just on this issue.
Thank you, Chairman. I've got to compliment Paul on his grasp of a really complex situation. But I was sitting listening, and it reminded me of the County Council when I first became the leader. And there were 2 or 3 problems. One was getting the organisation to understand that it was one, and the different parts of it were working for a common cause. And looking at the paper, the page that Richard Cox highlighted, there's certainly something about people are working really incredibly hard in some parts, and possibly sacrificing the savings they're making to help somebody else, whereas there are others that just through the sheer complexity of the whole system are just saying, well, I want more, I want more, I want more, and probably aren't actually looking at how they're working themselves to be innovative and transformational in a very difficult situation. And I'm trying to take it out of the medical bit and into a system analysis, because there are mentions in the paper about one collective aim. So it may be that when you're looking at the improving the population health, which is a red and an amber and a grey, that will impact on the rest of the system longer term. So quite often, Paul, you're probably having to look at short term, and people are screaming about weights on the very much the short term, when actually the solution is farther upstream and trying to make people healthy so that we can drop the workload. There will be workload because of people having accidents, there'll be workload because of ill health or whatever, but trying to make people healthier will help the system. So it's a really complex picture, and I have to compliment the report, but it is so complex that you cannot actually see the solutions, which are in themselves very complex. And I keep going on about this committee's role in public health and district and borough council's role in it as well. But there's something about the GPs, and you know, and we really have got to sit and think very carefully as the next stage of the integrated care board system about how we can help them to get these long-term aims. That may be the council, local authorities' role as public health. But, you know, thanks to the report, it's just a comment rather than a question, you know, but maybe a question is, do people understand when they do make savings, they're sacrificed elsewhere? Because when you're making savings in an organisation like the County Council and you're putting it into a collective pot and it's been gobbled up by children's services because nobody's doing anything about the amount of children that ended up in care, after a while, and it's natural human reaction, you start thinking, well, I'm going to go quiet about savings because I'll just keep them in department. So I'm just wondering if that's happened.
Sounds very much like a rhetorical question, Paul, but let's wait and see what your response is. I think you hit a really good point. I think you hit a really good point, though, Philip, and I'll come back to that in a minute once Paul's answered it.
I agree. I think they're all really, really good points. And yeah, thank you for the recognition of the complexity of it all. Just a few things as reflections of what you've said. One is that upstream piece is probably one of the greatest frustrations for us in the ICB. That's the bit that we're kind of here to do. And it is so difficult because you constantly pull back to that short term, as you say. And we know that the solutions have to be long term, and it's just devilishly difficult. But just to give some assurance, we absolutely are mindful of the need to work on that longer term piece of population health. Otherwise, as you say, we'll never fix things. The second thing will be a personal observation, which you know now been on the patch for about 3.5 years, and we're getting better and better at working together. And that's within health, but it's between health and the two upper tier local authorities. I do genuinely think that, and I think that's the only way we're going to work our way out of this is by doing that. And then the third thing, just you point about kind of working together on the long term stuff. I'd often say to that is absolutely the more that we can. These conversations help me, and hopefully they help you too. Just thinking about, well, what are the things that are most important, because we just cannot do everything. So what are the things that we can do something about, and let's focus on those. And it's often a bit soul destroying, as you're saying, when you know you can't fix the whole world, you want to fix it, you can't. So what bit of the world do you fix? And just working together on that would be, I think, a very positive thing to continue to do.
Philip.
Yes, thanks, Paul, for that, because you've just reminded me, I used to tell people it's an elephant and you can't eat it at one go, but you can eat a steak. And it may be that we could do with a list of the steaks and the joints that we could eat.
Thank you for that analogy. Just let me follow up. I'll bring you in a minute, Bernard. I just want to follow up Philip's points because I think they're really relevant. So the first point I was going to make was this chart feels like a health chart. It's a really nice chart. I think you called it a heat map or a placemat, I think you called it. So I think that the chart that Philip's referring to and Richard refers to is a really useful one because it shows all the programs and all the projects that are ongoing. But it is only health. And it surprises me from the ICB, which is about the wider system, that there isn't anything there in terms of public health or the prevention agenda or social care. And I think that if there was some visibility on those, actually, we may find that some of the focus moves to those areas because the points that Philip makes about making sure the prevention agenda upstreams the need to intervene till much later on. That's the first point. Second point I'd make is in terms of the RED utilising population health management techniques, to me, that's a really strategic aim, and that the longer it takes to get that rolling, the more short-term cost we will be incurring. And out of the ones which were behind track with no mitigation, that to me felt them like the most strategic, and probably the one that disappointed me the most in terms of the chart. The third point I'd make is, I think it'd be really useful to try and understand what the financial impact of some of these elements being behind target or not even started. So, understanding the financial impact and the risk impact, I think would be quite useful as a backup to this. Because actually some of these things, may be minor and immaterial in the grand scale of the delivery of the overall plan, and some of them may be fundamental. And I just can't work that out from what's here. And actually putting a number to something might drive where the focus and the prioritisation is. And that brings me on to the final point I wanted to make, which was, do you know what, there's a lot on this page, a huge amount on this page, and trying to decide which are the 2 or 3 that must land, come what may, and maybe we redivert focus and attention. If we understood what the prioritisation was, not of everything, but maybe the top 3 or 5, then that may just help. And I'm sure that the ICS does have that prioritisation, just isn't shown here, and maybe that would be helpful just to make sure that we focus our questions and our concerns on those that are absolutely fundamental to making sure that you do get to where you need to get to this financial year.
Very helpful feedback. Thank you, Chair.
Okay, I think that brings us on to Bernard.
Yes, there's not a lot to say after all of that, Chair, and thank you for summarising it so well. All the themes that we've touched on today are, mental health, primary care, and don't let us forget dentistry, which a lot of people are encountering some significant difficulties with dentistry at the moment, not alone with access, but people are telling me they can't afford to go privately anymore, so they may have to revert back to the NHS. So someone needs to get a grip of dentistry, let alone everything else we're talking about. It's a very difficult listen today, Paul, to hear you comprehensively and clearly define what the challenges are, and I thank you for that. But this broadcast, this meeting is being broadcast, and the public if they're watching the webcast, will have heard exactly what we've heard. And some people who are a little more concerned than others will be beginning to worry about what is happening to our NHS. And the financial insight that you've given us makes me feel extremely uncomfortable at the moment. And we talk about people who are ill, chronic people, people who have a chronic illness aggravated by comorbidities. They must feel at risk. So it'd be really interesting to see how your policies unpack over the next few months, mainly to give the public some assurance that we're going to get this right and that they are safe and they're going to live a life that's expected of them, really. Thank you.
Paul, with you.
Yeah, thank you, and yes, it's a hard listen. I appreciate. I think I definitely can give assurance on the safety point. The NHS is filled with professional people who dedicate their life to keeping people alive and well, and that's, I suppose, why we've got a financial deficit, because people will not go over that line, and CFOs, although we're finance people, we wouldn't push people beyond that line either. So, you know, we are clear about the need to keep services safe, but then you're into the services that people really need, but it's a grey area, and that's really where we just have to work now, is that clarity of prioritisation, but fundamentally addressing the chronic situation as you articulate it. I wish I had answers to all of that, but what I can say, going back to the example I gave of the recovery plan, it does genuinely, fill me with hope for this system, because we do something together which is going to make it better for people. That's very motivational for our workforce, and it will save money. And it's that way around. We've got a chance. When we've got to save money because that's going to make people worse, well, you just can't. You can't win that argument, and we wouldn't want to try and win that argument. So at the moment, I'm not in a doom and gloom space. I'm looking ahead, thinking this is really difficult. Sure, but I'm not in a doom and gloom place. We've got something we can do about the CHC, which is going to result in a huge financial benefit to the system, which will allow us to keep those services safe. As I say, I just want to give that assurance that in terms of safety, that would always be a line that we would not cross.
Bernard, did you want to come back? Janice, did you want to come in?
Yes, please, Chair. Sorry, I had to pop out earlier on, and hopefully I've picked up on the salient parts. A couple of the pieces that I was particularly inquiring about, one was mental health, which I think has already been explored, and we've taken that action away. Hopefully I haven't missed any of this part, but a couple of the pieces that I've heard since, we've got a statement on page 20 that says capital is forecasted as expected, however medium-term challenges remain and require national monies to achieve plan. If that hasn't been touched on already, if I could just have some elaboration on that. And I really appreciated the content of the report. For me, we could see quite clearly the challenge therein, and I think my colleagues have already made sufficient comment on that as well. But it certainly is an insightful document, even if it does make challenging reading. But in your response, Paul, you came back with the fact that you're optimistic. Can I ask how long your optimism is likely to last? And if we've got some idea of where we might be? I've asked that in a nice way, hopefully.
Paul, with
Thank you. I'll come quickly to your capital question. Yes, we capitals are rather a strange bit of a dark art in the NHS, to be honest, in terms of the way allocations work. So at this stage, we're just flagging a potential issue, but we're not expecting it to be a problem. We've identified the capital priorities that we have. I mean, that's not to say we haven't got. We'd like to have a lot more capital than we have, but in terms of the essential capital to meet the requirements of RAC, which is a big issue in terms of some of the operational stuff around replacing assets that are fully depreciated. All that stuff is okay. So we're managing capital. your bigger question about optimism, how long does that last? I remain optimistic. I just think it's always hard to put a number on this, but you get a sense that people are working together and trying to do the right thing, and that's worth just so much. And I suppose all my career, it's quite a long career now, we've never had enough money. We'd always like more. It's particularly difficult right now, I must say. There's been periods in my career where it's been particularly difficult. This is one of those moments. But I do feel that we've got the right working arrangements now within health and between health and social care to do the best that possibly can be done. I know that sounds like a slightly glib response, but what we can't do is we can't solve things which are in politicians' hands, but what we can do is do the best that we possibly can with what we're given, and that's why I feel optimistic. I don't know if that addresses your question, but that's what I meant by it.
Janice?
Yeah, it does. Yeah, as I say, it was one of those comments and a question, but really it's about the time frames in terms of, you know, when are we ideally being able to turn the ship around in some respects. We know that it takes an awful long time to do that, but just indicative time frames, I think, is probably helpful.
Yeah, I think the ship is not heading for an iceberg. That we are overspending our money. There are some operational problems, but fundamentally, it's for clinicians to come to you, I suppose, and answer this question. But services are safe, they're being developed, but we're spending too much money. That's basically where we are right now. If the question is when are we going to get rid of all the financial deficit, I don't know. Looking ahead to next year, I don't know how the NHS will live within its resources without some fairly significant changes. But that's a conversation that needs to take place between the NHS and central government, and then it's a question of us living within that. I mean, the only thing I can do with working in an ICB is make sure that our ICB is at least as good as anybody else. We're doing the best that we possibly can with what we're given. I can't affect industrial action. I can't affect the amount of money that we're given. But what I can do is make sure that we continue to do the best we possibly can with what we've got. And again, I'm not giving you the answer you want, which is when will the deficit go, because I don't know. But what I do feel at this moment in time, I do feel optimistic that we are going to be relatively in a good position as most ICBs, as most systems, because of the way we're working.
Thank you, Janice. Thank you, Paul. I've got no further questions, Paul, so I should just make one point in response to Bernard's question in terms of dentistry, that we do have a piece on the 31st of January 2024, bringing back the, I think he was looking specifically at the needs-based, the excess demand on dentistry, and that's coming back separately to committee at that stage. So I should just make members aware of that. Paul, can we thank you for your paper? I think the document takes me back 4 or 5 years, in honesty, back to all the discussions of historic deficits and then interest payments on the debt and all the all of the financial deficit discussions, which is really sad because after 3 years of break-even or better position, we would have been able to have written that off, and that obviously is a disappointing point of view, having done 2 difficult years to get to that point. So it is what it is, and I think we understand that everyone is doing their best in a very complex situation, and after all, we're dealing with people at the end of the day. And I think your point about people are behind delivery, I think is really well made. From the report, we're going to just ask for a report on CAMS, please, and I think we should just note your optimism. At that point, we will move on to the next part of the agenda, so you're welcome to stay or to go. And I think that takes us on to item number 7, which is the District and Borough Health and Scrutiny activity. Anne, are you waving because you want to... Oh, okay. I thought you were going to add to your report. Is anyone wanting to add to what is in front of us today? I'll take that as a no, so that makes it a very brief item. So with members' permission, we'll move on to item, just wait. I should just reference that obviously alongside the district and borough scrutiny activity, there's a whole range of working groups that are going on at the same stage, which include women's health integrated care hubs for the north of the county and an adult social care assurance working group, which is prior to the CQC inspection. Right, in terms of moving on to item 8, work programme, you will notice in terms of the work programme that there is diarised in February a couple of visits to the 2 mental health trusts, that's North Staffs Combined plus the Midlands Partnership Foundation Trust. They are happening in February. There are a limited number of places to be able for members to join that, but equally we need the same members to attend both sessions. Can I suggest if anyone wants to attend those that they contact Zach, please, and make sure that he is aware of your interest. And secondly, there is an element on the forward work programme which is talking about the acute trusts. And whilst once a year we generally look at the quality accounts of the trusts, I think this year it may be useful to run a separate piece which looks at the performance of those acute trusts, that's principally UHDB plus UH&M, just to look at actually what their forward plans are, and so that we can interweave what's happening at ICS level, at commissioner level, with what's actually happening on the ground, because I think sometimes we miss the detail as to what's happening on the ground, and we might just want to scrutinise that in a bit more detail. And we can use it to triangulate against, just to make sure that what's being told to us by the ICS actually ties back with what the providers are indicating. Are we happy with that as a work programme? There you go. And on that basis, I will wish you, everyone, a happy Christmas and a brilliant New Year. I think we've had a long and sober meeting today, and please feel free to help yourself to mince pies and chocolates on the way out. Thank you for your engagement this last 12 months. Have a great and restful Christmas, and we will start again on the 31st of January. No doubt we'll be doing lots of other work behind the scenes in the meantime, though, so don't think that we're doing nothing for the next 8 weeks. Thank you. Meeting's closed.